Perfect. Okay, awesome. So I'm going to go ahead and just kind of get started with some introductions here. So just for those of you who don't know me, my name's Alexa. I'm the treasurer of the AGA. I'm also the acting chair of the education committee. I just want to thank everyone for attending. We're really excited. This is now the third webinar of our AGA series. I just want to go through some kind of housekeeping information here. So the session today is being recorded. That way we can access it afterwards and people who aren't present live can watch it. We just ask that everyone remains muted throughout the duration of the webinar. If you have questions, you can just hold them till the end. You can put them in the chat box and then Karina can answer them when she's finished with her presentation. After the webinar ends, you're going to get an email from me through the Google group that's going to have a link to the survey. You just fill that out. That's going to help us kind of track everything, and it's going to be how you get CEUs. If you're dialed in with your phone, which I don't think anyone is, but if you could just let me know who you are, that way I can count you as being present. And then lastly, if you're watching this on demand, then there's going to be a separate survey with a quiz that you're going to have to fill out to get CEUs. So today we're going to hear from Karina. She is one of our very own members of the AGA. She's a prenatal certified genetic counselor at Fetal Diagnostic Center of Arizona, which is located in Phoenix. We're really, really excited to have her presenting today. She's going to give us some information about kind of the prenatal specialty, and I'm going to go ahead and pass it over to her.
All right. Thanks for the introduction, Alexa. So I was hoping to focus on NIPT or non-invasive prenatal testing. Really chosen to focus on this topic because this is a technology that's garnered international attention and it's rapidly evolving. And so we are broadly looking for new ways to expand the scope of genetic conditions for which we are able to assess in a non-invasive screening manner. So I'm hoping to walk you through a little bit of the history that's helped shape where NIPT testing stands today, and also spend a few minutes of time talking a bit about some emerging research that may allow us to widen the scope of different types of genetic etiologies beyond traditional chromosome abnormalities for which we may be able to evaluate in the future. So I do not have disclosures of any type to address today. And our objectives for this morning are twofold. First, we're hoping to evaluate the benefits and limitations of NIPT screening across the entire scope of the prenatal population. And I'm also hoping by the end of today's presentation that you all gain a bit of an understanding about some new research developments and how those may apply to our ability to evaluate the fetal genome with NIPT in the future. So the applications of NIPT from a clinical screening perspective really exploded, beginning with a groundbreaking research publication back in 1997. So Dr. Dennis Lowe, based out of Hong Kong, was the first individual who led a team to successfully identify fetal DNA in a maternal plasma specimen. So very quickly, goals for NIPT screening emerged to develop an accessible tool with a high sensitivity, low false positive rates, so that we could accurately identify pregnancies at increased risk of fetal aneuploidies, thus reducing the risk of procedure-related complications associated with prenatal diagnosis. So effectively 10 years after the introduction of NIPT screening in the US market, where do we stand? Have we met those goals? So it'd be a bit remiss to not first start with a quick review of NIPT principles and terminology. So when we refer to cell-free DNA, we are talking about DNA fragments, about 140 to 200 base pairs in length, typically derived from apoptotic cells. Now, during pregnancy, the bulk of our cell-free DNA is actually going to be maternal in origin, mostly derived from white blood cells or adipose tissue. But in any given maternal plasma sample, we are going to expect about 10% of the cell-free DNA contribution to be pregnancy in origin. And that's specifically derived from the cytotrophoblast of the placenta. And that's a term that we refer to as the fetal fraction. Cytotrophoblast fraction really just doesn't roll off the tongue in quite the same way. So that's the various specimens that we're examining with our NIPT sample. Now, for analysis, once a maternal plasma specimen reaches the laboratory, the cell-free DNA is isolated, and then it is sequenced either using whole genome sequencing or employing more of a targeted sequencing approach, looking at specific chromosomes of interest. Then a variety of different analysis algorithms are utilized. Either we're employing a counting technique where we are comparing the cell-free DNA against either a normalized chromosome volume, we're using a Z-score type analysis, we're amplifying the specific chromosome regions of interest for analysis. And some laboratories use a more indirect method of analysis by distinguishing between maternal and placental SNPs and using that ability to evaluate the genome. And then in the same vein, we also want to make sure that we're employing tools to evaluate the fetal fraction. We want to make sure for every NIPT specimen that we have the means to evaluate that we have a representative sample of pregnancy DNA to complete appropriate analysis. So really employing that as a quality control metric. Again, various lab-based technologies can be employed to evaluate for the presence or calculate the percentage of the fetal fraction in any given sample. And laboratories use a different combination of sequencing, analysis, assessment of fetal fraction algorithms to report test results. So in its original iteration, NIPT was designed to screen for our classic trio of trisomies 13, 18, and 21 with the option to add in screening for sex chromosome abnormalities. Now, they selected those because they are the most frequently occurring chromosome abnormalities in the population. And this pie chart really just demonstrates the distribution of how common these various chromosome abnormalities are. So we expect that in NIPT screening with inclusion of sex chromosomal aneuploidy analysis, that's going to encompass really everything between or up to 80 to 83 or 84% of chromosome abnormalities that we would expect to encounter in pregnancy after 10 weeks of gestation. So the rare chromosome abnormalities, which wouldn't be encompassed, giving you a snapshot of what exactly those represent. And those may range from triploidy, rare autosomal trisomies to a whole spectrum of structural chromosome abnormalities that would not traditionally be included in this analysis. So early information about the performance of NIPT screening for these common aneuploidies. So first looking at singleton gestations, meta-analysis was employed to examine clinical validation studies, clinical implementation studies for which outcomes were available in greater than 85% of the entire study population. So for meta-analysis, we do see high pool detection rates, also demonstrates low false positive rates as a screening tool. Early information regarding performance of sex chromosome abnormalities was reassuring. However, they just felt that there were really insufficient case numbers for further assessment. There was also an initial concern that because many of the early implementation studies were targeted to a high-risk population, there was concern that perhaps NIPT screening may not be quite as robust in a low-risk population. However, they did also determine that after a separate subgroup analysis, that the performance of NIPT was also robust when we look at studies exclusively examining mixed high and low-risk populations or just low-risk populations. Now, twin gestations obviously don't occur nearly as frequently as singleton gestations, so we're a little bit more limited in our data set. But again, they're also demonstrating high pool detection rates, low false positive rates. Finally, these meta-analysis calculated a negative likelihood ratio. So in the setting of a low-risk NIPT, we have a way to effectively counsel those families about their reduced risk. Also, meta-analysis did identify that across all technologies of sequencing and analysis, each combination of techniques appears to perform equally well. Now, that said, there could be some times where one type of analysis technology may be preferred. So for example, if we are using a SNP-based analysis to distinguish between maternal and pregnancy haplotypes, we can use that ability to identify the presence of a third haplotype. So may offer the ability to distinguish for evidence of a vanishing twin, evidence of triploidy in certain cases. In the setting of a twin gestation, a SNP-based analysis allows us to distinguish zygosity of that twin gestation, calculate individual fetal fractions, and also provide individual assessment of fetal sex. But unfortunately, if we're relying on the ability to distinguish between maternal and fetal haplotypes, we may encounter non-informative SNPs, and that can increase the no-call rate in those specimens as compared to using a counting methodology. Also in pregnancies with known consanguinity, long regions of homozygosity, again, may limit our ability to distinguish between maternal and placental haplotypes. And so in those cases, a counting method or a massive parallel sequencing may be our preferred methodology. So typically it's best for most counselors to have multiple different laboratories or multiple different techniques in their genetics toolkit to encompass a broad scope of the population. Reporting format. So NIPT reporting is different as compared to other types of prenatal screening methodologies like maternal serum screening or nuchal translucency screening, and that we're not calculating a specific numeric risk, but that we're reporting these results as a screen positive or a screen negative. Occasionally, some of the laboratories do also calculate a post-test risk. And again, positive screen result. So with the reporting, there was initially some voices of concern about the language that was used surrounding test results and test reporting. And I've chosen a few snippets that were on original laboratory websites. This was also language that was included in patient as well as provider literature. And notice the performance, the language, the emphasis on sensitivity, never maybe 99% accurate. So really the catalyst for change was a Boston Globe article published in December 2014. It was an investigative study that examined patient as well as provider perceptions to the accuracy of NIPT screening. And they emphasized there was concern that families were so confident in these NIPT screening results that they may be choosing some irreversible pregnancy management decisions based off of an NIPT alone. The study did include publication information from Peter Dar and his group. His group was following up on 356 cases of high-risk NIPT. Of those cases where no diagnostic testing was performed, 16% of women chose to terminate the pregnancy because they understood the NIPT to be so accurate that there was no need to pursue any further analysis. And so that issued a very prompt statement from the Society of Maternal Fetal Medicine. Cell-free DNA is not just a simple blood test. There are tremendous implications to interpreting this information and significant consequences if we misunderstand this testing. So out of that, there was a pretty concerted push to readdress or initiate that broader conversation about how we counsel, how we report these test results. And that included discussion with the National Society of Genetic Counselors, as well as the Perinatal Quality Foundation. And really starting with an acknowledgement that a test can have both a high sensitivity and specificity without necessarily being a good predictor of the presence of the disease in the population. So there was a move to reporting testing by utilizing a positive predictive value. So that represents the likelihood that a screen positive result actually reflects a true diagnosis. And you can see that the positive predictive value is actually going to vary depending on the a priori incidence of the condition in the population. So using this graph, if we hold a sensitivity at 99%, we can ramp our specificity of the test all the way up to 99.9% across that x-axis. And we see the positive predictive value on the y-axis. we're going to see a widely different positive predictive value depending on how frequently we encounter that condition in the population. So out of this, with the cell-free DNA screening tool was developed, interactive calculator for providers to calculate a patient-specific positive predictive value risk. So you click on your conditions, your a priori risk, and then you get a reportable result. This is based on the meta-analysis data that we reviewed a few screens earlier. And this may be valuable in counseling because not every laboratory provides a patient-specific positive predictive value in screen results. Some labs do not issue a positive predictive value with their screen results. So other methods of obtaining that information for counseling purposes. But with any screening technology, our power is going to be in diagnostic evaluation. So this is publication from a large referral laboratory for which they report on outcomes of patients undergoing diagnostic testing on the basis of a high-risk cell-free DNA or NIPT screen result. So again, we see positive predictive values reported here, but also notice a difference in what they determine to be calculate those false positive rates, and notice that there's a difference between that and what was reported based on meta-analysis. So this particular study commented that they were only given the information as was provided to them on the test requisition. The back end, they had no follow-up on those cases. They don't know of other potential etiologies that could have accounted for a screen positive result that may have ultimately led to the diagnosis being excluded, but we may still have some additional information that could account for that. So with that in mind, we'll talk a little bit about NIPT discordance, giving you here just a quick snapshot of some of the various plausible, well-documented biologic explanations that could account for a high-risk NIPT screen report, even though the diagnosis itself may not be present. So let's start with mosaicism. Mosaicism, this is a very simplified diagram of all different types of mosaicism, but approximately 72% of confirmed mosaicism is confined placental mosaicism. And even in the setting of confined placental mosaicism, this isn't necessarily an innocuous finding. Pregnancies with confirmed CPM are at an increased risk of other adverse obstetric outcome. So that may include increased risk of maternal preeclampsia, IUGR, or growth restriction. Either of those issues that develop in the pregnancy may increase the risk of premature delivery. And so those pregnancies are best managed by more careful fetal surveillance. Amongst maternal causes for discordance for NIPT, the most likely we're going to encounter is maternal mosaicism for the X chromosome. And first, it's important to acknowledge that mosaicism, somatic mosaicism for the X chromosome has been well documented in lymphocytes, and somatic mosaicism of the X chromosome also does appear to increase with increasing maternal age. Along the same vein, thinking about maternal chromosome abnormalities, this more recent publication in 2020 followed up on all 106 cases of an atypical NIPT report where a maternal X chromosome abnormality was suspected. Those women were given diagnostic testing via chromosome microarray analysis. 100 cases of maternal chromosome abnormalities were confirmed for a PPV of 94.3%. Interestingly, the lab went back and did post hoc analysis on this NIPT samples for the women who had a negative CMA analysis, and they suspected low-level mosaicism for monosomy X in 3 of those cases. But because the confirmation testing was done by CMA rather than by karyotype analysis with extended cell counts, they were never able to confirm. So another etiology for NIPT discordance that's gained a lot of attention is the potential presence of an occult maternal malignancy. So based on this early publication by Diana Bianchi's group, we can see the table on the left that for every type of atypical or high-risk NIPT screen result, there were maternal malignancies identified, but really the most striking association was in the setting of an atypical NIPT result screened positive for multiple aneuploidies. Nearly 18% of those multiple aneuploidy high-risk cases were identified or confirmed with a maternal malignancy. And just a reminder that the cell-free DNA encompasses maternal DNA as well, and that may also arise from maternal tumor tissue. Again, give us a breakdown of all the different sources that can encompass a cell-free DNA specimen during pregnancy. More recent follow-up of 450,000 NIPT samples identified 40 neoplasias. 18 of those were malignant, 11 of which were not known to the patient at the time of their NIPT blood draw. And so we see over on the right, the breakdown of the malignant neoplasias, most common lymphomas and breast carcinomas. Now, interestingly, 20 of the cases were benign neoplasias, all of which were uterine leiomyomas. And so you may be thinking, well, wait, maternal fibroids are actually an incredibly common finding in the reproductive population. We see them all the time during pregnancies, but many fibroids are small. The most common chromosome abnormality identified in fibroid tissue is a balanced translocation. So outside of the scope of the algorithm used for NIPT analysis. But as fibroids increase in size, they may start to acquire new chromosomal changes. And it's suspected at least that those large fibroids may be gaining some new imbalances that may be captured by the NIPT screening algorithm. So there are no recommendations about whether or not to offer an NIPT to someone with a fibroid, but it's widely acknowledged that patients with a confirmed malignancy should not be offered an NIPT screen just because of the chances of capturing a result that may be more reflective of that malignancy. So what do we do with these patients? If we have a reason to suspect aneuploidy based on NIPT, unfortunately, there's really no clear consensus at this time, but some suggestions for follow-up include thorough family medical history, baseline CBC, chest x-ray, consideration of MRI, consider repeating the NIPT post-delivery. If it's resolved, we've answered a question, but if it's not resolved, perhaps consider referral to oncology, but perhaps a conversation with your local oncology group, as this is unlikely to be a common source of referral for them. So let's spend a few minutes looking at some future directions of utilizing NIPT, maybe perhaps for malignancy research, as well as utilizing this technology may evolve in our ability to follow up on these patients for potential suspected malignancies. So there is evidence to demonstrate that cell-free DNA does carry a tissue-specific methylation profile. So publication by Sun's group a few years ago was looking to simultaneously construct a map of all the different cell-free DNA contributions to a plasma specimen. So they used a combination of bisulfate sequencing and these methylation profiles to construct a plasma DNA tissue map. And then once they developed the tool, they validated their study by completing this analysis on prenatal cases. They now analyzed patients with confirmed hepatocellular carcinomas, also looked at a group of patients post-organ transplant just to monitor for any evidence of tissue rejection. And so here's the panel that they identified, and they have successfully mapped the various contributions in a series of prenatal patients. Interestingly, during their validation analysis with their prenatal subgroup, they did confirm a case of follicular lymphoma because of a significant overrepresentation of B cells in that plasma sample. After evaluation of family history and workup, follicular lymphoma was confirmed. Another more recent study actually built upon that technology. This screening tool was looking to develop a tissue map of origin that could be potentially utilized in the future as a general population screening tool to detect a wide range of different neoplasias, or different malignancies at various stages of tumor development. So again, they validated their study by using confirmed malignancies, and they successfully determined that against their predicted tissue of origin map with these unique methylation tags, they're actually pretty successful at confirming here along this diagonal axis a number of cases where the algorithm was able to successfully identify and trace the type of malignancy identified. So it's an area we'll be very interested to see in the near future where this takes us, and this may be incorporated as a future follow-up for our pregnant patients that have that high-risk NIPT suggestive of the malignancy. So after going through a couple different maternal etiologies for discordant NIPT, really highlights the need for careful consideration of both pre-test and post-test counseling. And that includes some official recommendations that in pre-test counseling, patients should be aware of the potential of identifying an incidental finding, including those that could be maternal in origin and results of which may have some implications for her own medical care. So quick case example, 26-year-old Caucasian female, refer for genetic counseling due to an isolated club foot, family pregnancy history otherwise not unremarkable. Following counseling, patient declined prenatal diagnosis. Eventually, she later decided to pursue NIPT screening. And the genetic counselor got a call for atypical finding on NIPT, suspected maternal sex chromosome disorder. Patient, following subsequent counseling, ultimately underwent diagnostic testing. Chromosome microarray analysis was confirmed trisomy X. So the genetic counselor reached out to the patient, and genetic counseling was scheduled, but then ultimately the patient called back, canceled the genetic counseling appointment. Follow-up ultrasound for clubfoot. The MFM provider chased down the genetic counselor and had the genetic counselor meet with the patient in person. And the genetic counselor was concerned that the patient was uninterested in the information, really didn't seem engaged, didn't want to address those results. Ultimately, they were never able to form a close or a good rapport. But the counselor's takeaway was that this was distressing to the patient. And in the end, this may have been information that she really did not benefit from. And again, re-emphasis of the importance of both pre-test, post-test counseling, including the potential of uncovering incidental findings. So moving on to other causes of discordance results, this could include vanishing twins, just based on the idea that there's a higher rate of cellular breakdown from the fetal placental remains of the demised twin, and that higher rate of apoptosis may skew or interfere with accurate NIPT reporting. And there is documented evidence that cell-free DNA from confirmed demise may remain in plasma 8 weeks post-documented loss. So another potential explanation for discordance of results, and really reminder for a careful review of pregnancy and reproductive history to examine for that as a potential discordant etiology. So other causes of discordance could be specific to a discrepance of reported fetal sex between ultrasound or perhaps documented genetic sex by IVF embryo transfer as compared to an NIPT reporting. So again, follow-up of over 1 million cases. This laboratory identified 91 cases of reported discordance. And then working through their follow-up algorithm, they identified that there were 30 cases of disorders of sex development, accounting for 36% of that sex chromosome discordance. And so I've broken them down here by category, both male and female disorders of sex development, as well as sex chromosome disorders of sex development. So when we see fetal sex discrepancy, there can be some other considerations to take into account, and that's close review of patient personal history. Is there evidence of a recent blood transfusion? Is there perhaps a prior history of an organ transplant? Was there a vanishing twin or evidence of a multiple embryo transfer that could account for the discrepancy? And then the laboratory also, or the report also proposed an evaluation algorithm, including reaching out to the testing laboratory for validation analysis, as well as thorough family medical pregnancy history, detailed ultrasound, and then as indicated, referral for maternal fetal medicine, genetic counseling, diagnostic testing, and then further referral to pediatric subspecialty as may be indicated. Another quick case example. So 29-year-old G2P1, she was originally referred to MFM for an anatomic survey and echocardiogram due to suspected congenital heart disease on outside ultrasound. Unremarkable obstetric history. She came in with a low-risk NIPT in a male fetus. So ultrasound performed, surprise, female fetus. And so she was sent for same-day genetic counseling referral. First step, reach out to the laboratory. The lab director was going to review the clinical data. While going through family and medical history, we uncovered that the patient underwent single lobe liver transplant at 6 years of age. Her father was the donor. So between follow-up ultrasound, thorough assessment of anatomy, as well as follow-up conversation with the laboratory director, everyone agreed that this was a plausible etiology. Nevertheless, the patient did undergo comprehensive genetic counseling. She was given the option of prenatal diagnosis. She declined prenatal diagnosis. She delivered a healthy infant, and the pediatrician was given an update just so that this information was on their radar for any future consideration. Talk for a minute just about test failures. So when we talk about test failures, it's ultimately a specimen for which there was no reportable result. And that can happen for any number of different reasons. When there's a failed test report, we think about an increased risk of an aneuploidy, perhaps outside the scope of the chromosomes measured, especially because certain aneuploidies, particularly trisomy 18 and 13, are associated with a low placental volume. So low placental volume, perhaps just a low fetal fraction. I've also listed a few other just common etiologies we consider for low fetal fraction that may contribute to a failed test result. But there's more recent evidence to suggest that failure to obtain an NIPT result due to low fetal fraction may additionally increase the risk of other adverse outcome. So preeclampsia, gestational diabetes, for which we actually may be able to tailor individual prenatal care. And there's some evidence to suggest perhaps a modest increased risk for preterm delivery and lagging fetal growth, again, which may benefit from some additional fetal monitoring. So let's take a few minutes and talk a little bit beyond routine screening for chromosome abnormalities. First type of supplemental NIPT screening that was rolled out was screening for select recurring microdeletions. And probably the most compelling argument one could make for inclusion of microdeletions in NIPT screening is the frequency at which these deletion syndromes occur, especially as compared to other genetic disorders for which screening is available, or at least there's some society guidelines to discuss with patients. Now, implementation of microdeletion screening, testing, validation studies were really just fraught with one complication after another. There were small sample sizes. A lot of the labs incorporated artificial specimens. They used mixed cell samples, and really we just didn't have a lot of robust data. But in follow-up, looking at real-world performance, this is again data from a reference laboratory, and where they followed up 349 cases of high-risk NIPT for chromosome microdeletions. So they found across all referrals, the combined positive predictive value was 9.2%. But they did make a few other interesting notes that of all confirmed cases for the microdeletion in question, 39% of those samples were found to have another significant copy number variant. And then amongst cases for which the microdeletion in question was excluded by prenatal diagnosis, the laboratory did document another significant finding in almost 12% of those samples. So suggesting that some other type of copy number variant imbalance was caught in that algorithm. And so they had suggested that in the setting of a high-risk NIPT, that array analysis may be the preferred methodology just as compared to FISH. And so we want to reference back to another publication from Dennis Lowe. And based on laboratory experiencing, looking at the frequency of these recurring microdeletions, if we only perform a targeted analysis on these well-defined microdeletions, we're only capturing 25% of clinically relevant pathogenic copy number variants. So it makes a bit of a case for, well, should we perhaps consider and expand the scope of screening to a genome-wide analysis? So this is a publication out of Belgium, published this year. And Belgium has a national health system. And so they implemented a protocol to offer genome-wide NIPT to all pregnant patients. Now, the Belgian Genetics Ethics Committee felt that screening for sex chromosome aneuploidies was a bit controversial, so sex chromosome analysis was not included in their NIPT protocol. However, all pregnant women underwent a nuchal translucency ultrasound at 12 weeks. Obviously, any significant findings were addressed, and patients had the option of prenatal diagnosis, but low-risk nuchal translucency ultrasounds, patients were given the option of NIPT screening. Universal approach to results disclosure, anything low risk or screen positive for a common aneuploidy was addressed with the referring obstetrician and as appropriate given the option of prenatal diagnosis. But any increased risk of a secondary finding generated a referral directly to clinical genetics. And they also commented or developed very specific criteria for reporting of any suspected maternal copy number variant. Assessment for both clinical and technical relevance, as well as confirmation of the technical validity of the specimen. And Belgium has 8 genetic centers at which all prenatal diagnosis procedures are performed. And so their diagnostic protocols included appropriate testing based on the high-risk result. Now, aneuploidies that have been documented to be associated with uniparental disomy, which I've included. They also underwent separate UPD testing directly off of the amniotic fluid. Anytime a discordant NIPT result was reported, placenta was requested to be collected at the time of delivery. And then obviously CMA analysis was ordered as appropriate based on indication. So results, firstly for the common trisomies 13, 18, and 21, no significant reporting difference in positive predictive value as compared to prior publications. Of their specimen, of their study group, they identified other fetal aneuploidies in 0.23% of cases. The overwhelming majority of those were rare autosomal trisomies. And so looking at the graph that's documented, we have the outcomes of each of those high-risk NIPT cases stratified by chromosome number. The green bars represent confirmed positive cases. Yellow represents confirmed confined placental mosaicism. Red documents cases for which the aneuploidy in question was not present in amniotic fluid or the placenta. Blue is cases for which the condition in question was excluded by amniotic fluid, but placenta ultimately was not available. And gray represents cases for which no invasive follow-up was available. So looking at rare autosomal trisomies or rare autosomal aneuploidies, they documented a positive predictive value of 4.1%. As a separate subgroup analysis for UPD testing of at-risk chromosome abnormalities, they documented an additional positive predictive value of 4.7%. In reference to fetal structural chromosome abnormalities seen in 0.07% of the entire study population. Table on the right shows distribution by chromosome number, where red indicates deletions, blue indicates recurrent or duplications that were documented. On follow-up analysis, they demonstrated a positive predictive value of 47% of patients who ultimately underwent diagnostic testing. And then we can also see reported maternal imbalances, and then maternal cancers were also reported in additional subsets of that study. So they argue that there is value to consider application of a genome-wide approach to NIPT, even in the setting of a low positive predictive value of those rare autosomal aneuploidies, when there's evidence that there is documentation or reports of confined placental mosaicism, we can still have some value or still utilize that information to monitor the pregnancy appropriately, especially those that may be at an increased risk of other types of adverse obstetric outcomes. So guidelines, where do various societies stand on recommendations for screening? And we see a pretty broad distribution of how these shake out. Pretty much universally, all societies agree general population screening is appropriate. Those that have reported a specific comment about twins are in favor, but we see a bit more of a broader distribution on where societies stand about recommending for sex chromosome abnormalities, as well as approach for expanded screening. The caveat that being that if those are offered, it does entail very thorough, detailed pre and post-test counseling. Spend the last few minutes just talking quickly about some other applications as we're expanding the utility of NIPT screening. I'd like to start with fetal RHD. So Rh negative women with an Rh positive partner are at an increased risk of a pregnancy with hemolytic disease. Now, RHD negative phenotypes vary based on ethnicity, and so I've included the distribution of the frequency of Rh negative status in the United States. But since the development of anti-RHD immunoglobulin prophylaxis, or RhoGAM, we've seen a very marked decrease in neonatal complications due to hemolytic disease. So the idea is that because right now RhoGAM is widely accessible, there's relatively low cost of this technology, there's a low demand for testing of fetal RHD status. The concern is that with inherent risk of a false negative for any type of screening, we may risk new cases of alloimmunization, but there could perhaps be some utility in the US of women who are already alloimmunized with a confirmed heterozygous partner, perhaps in the setting of a low risk NIPT, we may be able to tailor the recommended ultrasound monitoring or surveillance for those individuals. Monogenic disease NIPT. So single gene disorders. One approach is to utilize this in a custom setting where we've already documented a given couple to be at an increased reproductive risk of a monogenic disorder. And the technology is employed by digital droplet PCR, where you're amplifying and you're specifically counting your variant of interest. And we're going to measure that as a shift against the maternal baseline, where the fetal fraction is going to be important to allow us to document the level of that shift. So for a dominantly inherited condition within an affected mother, an affected fetus, we would expect to see a neutral, or expect to see the maternal allele ratio remain the same, whereas you'd expect to see a downward shift of the maternal variant allele ratio in a non-affected fetus. X-linked recessive, in the setting of a confirmed male fetus, we'd expect to see an upward shift as compared to the maternal ratio in an affected male, downward shift in a non-affected male. Females, we expect to see a downward shift in the setting of non-carrier female. Things perhaps get a little bit more interesting with autosomal recessive inheritance. Now, if we have an autosomal recessive disorder with a common pathogenic variant, so let's use the common SMN1 deletion as an example, we would expect to see either upward shift for an affected fetus, neutral shift for carrier, and downward shift for an unaffected non-carrier fetus. Compound heterozygosity should be addressed in a sequential manner. First, evaluate for the paternal allele. If it is present, then evaluation occurs for the maternal allele, looking either for a neutral shift if fetus is also a carrier for the maternal variant, downward shift if the fetus is not a carrier for maternal variant. So early performance data suggests 93% concordance with known clinical outcomes. 7% of cases reported in this small validation study were inconclusive, with the low fetal fraction really being the most common reason for for inconclusive reporting. So I can tell you the hardest part about implementing population-wide carrier screening is that it's so hard to get male partners to come in for carrier testing. And that's due to any broad range of reasons, taking time off of work, the cost of testing, lack of insurance coverage. And so one study documented that in screen positive women for an autosomal recessive disorder, we were only able to capture 41% of dads who underwent the screening. And so some labs are attempting to bypass the need for paternal DNA, and they run basically a reflex evaluation. So if mom is identified as a genetic carrier for a recessive disorder, the sample is automatically reflexed to cell-free DNA analysis, first for the presence of that maternal variant, and then if indicated, they move on to a screening algorithm to check for evidence of a second pathogenic variant. Right now, only limited to very common recessive disorders, so including cystic fibrosis, spinal muscular atrophy, and alpha and beta globin hemoglobinopathies. They do report 99% sensitivity and specificity. And lastly, NIPT for de novo events. So these are preset panels. They are targeting genes or genetic syndromes that statistically occur due to a high rate of de novo events. Some of these are associated with non-specific ultrasound findings, but many of them are. So the largest area of application to date really has been for patients with some non-specific variation on ultrasound. Increased nuchal translucency could prompt referral for NIPT screening to include Noonan syndrome or other RASopathies. Ultrasound images suggestive of skeletal dysplasia. Clinical validation again demonstrates greater than 99% sensitivity and specificity, but this also can be a helpful adjunct test while families are thinking or waiting to meet the appropriate timeline in pregnancy to undergo prenatal diagnosis, or while we might be waiting for CMA analysis to come back. This at least allows us to screen or get some data input about some of these other etiologies that could perhaps account for an increased nuchal translucency. ACOG has issued a statement. While this is available clinically, we are nowhere near able to provide enough data, and many more studies are needed to determine if this is appropriate for the general population, and that essentially we're lacking a positive and negative predictive value information. So ACOG does not recommend single gene cell-free DNA screening during pregnancy. Quickly, whole genome NIPT not available, but there is a proof of principle study that's been published to demonstrate that this is technically feasible, and a de novo single nucleotide variant has been identified on a genome-wide scale without the requirement or the use of maternal haplotype analysis. So let's talk about confirmations for just a minute. So prenatal diagnosis is always going to remain the gold standard, and that can be done either via CVS or amniocentesis. But in the case of an atypical NIPT screening, are there perhaps times where we may want to consider one procedure versus another? So a couple things to think through. First of all, what's the chromosome abnormality involved? And what's the positive predictive value specific to your patient? Thorough ultrasound to check for any ultrasound findings of significance is always recommended first and foremost. And then as a necessity, comprehensive genetic counseling. So we may counsel a patient differently who comes in high risk NIPT for trisomy 13 with a holoprosencephaly at 13 weeks gestation. That may be a case for which CVS is an appropriate technology. We would counsel someone a bit differently who had a screen positive for trisomy 18 with 0 ultrasound findings, at least an early first trimester with a nice normal looking nuchal translucency measurement. That may be a patient who should be counseled about the option or consideration of waiting until an amniocentesis window when we have the ability of actually evaluating fetal DNA. And then when we talk about prenatal diagnosis, what do we consider low risk? In the US, we tend to counsel pretty conservatively about our risks of procedure-related complications. But a recent meta-analysis suggests that maybe it's perhaps time to reconsider how we're counseling patients about procedure-related loss risks. So in sum, after meta-analysis, they documented that the weighted pooled procedure-related risk of miscarriage following an amniocentesis procedure is 0.11% and 0.22% for those undergoing a CBS. So just wanted to take a moment and circle back to our original question. When NIPT was developed, we set out some very specific guidelines. This is an accessible test, and we've met that criteria. There is a reported high sensitivity for NIPT screening. It's in the low false positive rates that really requires a nuanced conversation. From an analytics standpoint, NIPT does a great job at identifying variations to DNA, but careful consideration is needed because we have a whole spectrum of plausible biologic explanations that can account for discordant or discrepant NIPT, and that does require careful consideration when counseling our families. That being said, that probably makes our strongest case about the importance of really thorough pre-test as well as post-test genetic counseling for any patient who undergoes an NIPT, because there are some very significant nuances and considerations that we want these families to take into consideration. And so with that, it's Friday, so that means the perfect way to end is with some baby heterozygotes. So thank you all for your attention.
That was awesome. Thank you so much, Karina. If anyone has questions, please feel free to put them in the chat box. We can get to them either now, or if you're, thinking about questions you might have later on, you can also send them to me in an email and I could forward them on to Karina. If there are any questions, feel free to throw them in the chat. Okay, so I'll go ahead and read the question. So the first question is the vanishing twin only an issue for gender or for other things?
Great question. So vanishing twin can be an issue for any of the aneuploidies for which an NIPT screens. So it could be representative trisomy 18, trisomy 13, etc.
And for blood transfusion, same question.
Blood transfusion, that seems to be the greatest concern for genetic sex, specifically for our classic things, but in theory, yes, if someone received a blood transfusion with a copy number variant that had not been or was undetected. And then how long should you wait? And Vitae says too, meaning how long should you wait post blood transfusion? Yes, yeah. So typically for blood transfusion, you're going to want to wait at least 2 weeks. And yeah, I would say that would be appropriate.
And I got another question as well. So what are your thoughts in the consent process by the OBGYN or other providers ordering an IPT?
Sure. So consent process pre-test counseling should include discussion of aneuploidies that are screened, some conversation about other aneuploidies that are not screened. I really find that pie chart that I included in the presentation to be extremely helpful to show patients that breakdown, and that it's our job to always consider other chromosome abnormalities. Test counseling should also include the potential to uncover any incidental finding, to also review with families that there are other types of NIPT discordance and remind them. I like to say, look, Mother Nature throws us a couple curveballs. We know that there are rare events, but that are incredibly well documented that could give us some discrepancy between what your NIPT shows and what actually is present or truly representative of the fetal DNA. I also like to include examples. I give patients the example of identifying trisomy X, for example, in a female, because it's a relatively mild chromosome variation, and a significant percentage of individuals with trisomy X have no idea and have never had any reason to be worked up. And also give the examples of, give them a few real case examples just to demonstrate. Always remind them that prenatal diagnosis is the gold standard, and that would be done either via CVS or amniocentesis, and to take those into consideration when making decisions about what may be the most appropriate screening or diagnostic evaluation for those families. Let's see the question. Okay, so wondering what people are doing with reclassifications on carrier screening. So first question, so reclassification on carrier screenings. Yeah, I mean, you're right, that does get a little bit tricky. Those I've seen them come back months after patients been counseled. And then just to give a quick overview for the non-prenatal people. So when carrier screenings performed, results are interpreted, carrier status is reported out based on the validation or interpretation algorithms at that time. However, as carrier screening becomes more expanded, as variants, especially variants of uncertain significance, are being recategorized all the time, there are going to be individuals, we may get a report months later, sometimes years later, indicating that a variant previously of uncertain significance has now been recategorized as pathogenic. We do our best to reach out to those families wherever we can. Otherwise, we'll make sure to notify the referring obstetrician. And usually we're pretty good about having the ability to reconnect with those families and then potentially getting them set up for follow-up with the pediatrician, or if needed, a referral out to genetics.
I think that's all the time we have for questions. To answer the question about getting your slides, so I'm going to post the entire recording, I guess, of this shortly after we sign off, and then that link will go out to everybody via the AGA emails. And then the slides I can send, directly if you want just the slides and not the entire presentation. So I'm happy to do that as well. But in the meantime, if you have any other questions about Karina's presentation, again, feel free to send them to me in an email. I can forward them on to Karina and get you guys the answers. And then the next webinar is going to be on licensure and billing. It's going to be in either November or December. You'll receive an email from me just kind of with the link and all that other fun stuff later on. So for those of you who are watching today, you'll get a link, like I said, with the survey, so you can take that, get CEUs, and then we'll see you in a few months for the next webinar. And thank you again, Karina. That was really, really great.
Thanks, guys. Hope everybody has a great weekend.
Yes. Have a good weekend, everyone.